Good morning and welcome to the 16th meeting of the Citizens Participation and Public Petitions Committee in 2025. Colleagues, agenda item 1 is simply that we are content under agenda item 5 to consider any of the evidence that we have been hearing this morning in private. Are colleagues content? We are, thank you. The next agenda item this morning is a thematic evidence session on emergency cardiac care issues that have been raised across various petitions, and those are Petition 1989 to increase defibrillators in public spaces and workplaces, which has been lodged by Mary Montague, who I always just make a point of noting is the provost of my own local authority in East Renfrewshire, tabled prior to her appointment in that position. Petition number 2067 to improve data on young people affected by conditions causing sudden cardiac death, lodged by Sharon Duncan, who is the mother of David Hill, who was a parliamentary colleague here who died while playing rugby for the Scottish parliamentary team in Ireland. And petition number 2101 to provide defibrillators for all primary and secondary schools in Scotland, submitted by Peter Earle on behalf of Trequeer Primary School. So these are the three petitions and the evidence that has been raised in our consideration of them to date that we've drawn into a series of themes to allow us to explore the issues. And in due course, we will be hearing from the Minister in relation to these issues. But this morning, I'm delighted to say we're joined by Kim Castell, Policy and Public Affairs Officers at the British Heart Foundation of Scotland, Kirsty Morrison, Policy and Campaigns Officer at Chest, Heart and Stroke Scotland, and Stephen Short, Programme Lead for Out-of-Hospital Cardiac Arrest, the Scottish Ambulance Service. So a very warm welcome to all of you. Each of us, there are 5 themes, and each of us is going to lead on one of these sections, but other colleagues will jump in with questions. In responding, please, if you can indicate that you'd like to come in, just for the official record, it will be helpful for whoever the lead is of that section to say your name as you come in. Otherwise, they might not be quite clear who it, well, we'll know it was Stephen, I suppose, but it might not otherwise be entirely clear who was contributing. So thank you all very much for coming in to you. Are you happy for us to move straight into the discussion? Then you are. So the 5 themes that we have identified to have a look at are data research and guidance, public awareness, the provision of life-saving equipment and emergency preparedness, the preventative actions and protection of vulnerable populations, striking that the survival rate is a lot lower in deprived areas, and fifthly, the cross-sectoral policy, how these things bounce across different areas of responsibility. And the first of those themes is the data research and guidance, and Fergus Ewing is going to lead us in this section. Fergus.
Thank you, Convener. Good morning to our witnesses. Plainly, any medical treatment and process must be based upon the best evidence and data. It's pretty obvious. And one of the petitions before us, one of the several petitions, is asking to improve data on young people affected by conditions causing sudden cardiac death. So I did want, as the convener has said, to ask you each about your views about data research and guidance. And maybe the first question to ask is what data currently exists on sudden cardiac death in young people in Scotland? Is there enough data? Do you feel there are gaps? If so, how should they be filled? So it's quite a broad theme, I appreciate, but given the importance of evidence-based practices in medicine as the sound way to proceed, it's perhaps a good starting point. So what data exists and what are your views about what more might or should be done?
To kick this off, if you like. So Stephen Short, Programme Lead for Out-of-Hospital Cardiac Arrest, Scottish Ambulance Service. Absolutely. Data is the underpinning part of any of our programmes, not least out-of-hospital cardiac arrest, and we have a data-rich system for out-of-hospital cardiac arrest. We publish, on behalf of the whole strategy partnership in Scotland, the Scottish Ambulance Service publish a report every year. And within that report, as has already been alluded to, it breaks down into Scottish Index of Multiple Deprivation Scores and age, whether male and female. So we know the demographic and the age range of the patients having cardiac arrest. Of course, cardiac arrest is caused by multiple different things. It isn't just caused by the heart. It can have many other causes as well, which then impacts on the types of treatments we deliver. And perhaps within the data, that's some of the elements. It's not as well defined or understood. We can give broad themes in terms of the cause of it, but that kind of much granular data, perhaps, I think, isn't necessarily as available. It probably could be, but at this point, it tends to be slightly more higher level data that certainly we report on.
Okay, thanks. Can I ask Kirsty and Kim?
Yes, absolutely. Yeah, data is essential. The work we do at Chest, Heart and Stroke Scotland is always evidence data driven, as I think everyone around the table, my colleagues here, would agree. Just to highlight, our own focus as an organisation is more focused on after an event for someone, helping them to live well. We do invest about 10% of our work and resources into prevention, but we are more focused at the other end of the chain of survival when it comes to cardiac arrest. But we do believe that greater data would increase the ability to support movement on the issue that is raised in this petition. In terms of data available at the moment, I don't have more than you have yourselves, but I think it is clear to say that there are some data gaps there and some disputes. It also does seem like a tricky area when we look at sudden cardiac death. I know the petitioner has highlighted, for example, death certificates. It's not always going to be the best way to understand the full extent of the issue when they're not always going to be reported on there. So it's a tricky area, but we do agree that more data would be incredibly helpful. We are grateful for, the Scottish Cardiac Audit programme and others, which is the data that are starting to come through, because it does allow us to create our own strategies more effectively, and also, the health sector as a whole to understand that.
Okay. And Kim?
Thank you. Yeah, just to agree with my colleagues that I think the BHF is really supportive of kind of improving data collection and better research. I think I kind of want to highlight a bit of work that the BHF are kind of funding at the moment. So you might be aware that the Scottish Government funded a pilot on inherited cardiac conditions in the west of Scotland, and the BHF have funded 2 clinical coordinators to kind of roll that programme out to the rest of Scotland. So in short, the pilot is a service to help contact families with those who have sadly passed away from a sudden cardiac death, and that's been indicated on their post-mortem, to give them support and to kind of signpost them to kind of genetic testing, to gather better data, to gather better research, understand the risk factors a bit better, understand those kind of genetic relationships to who might be more at risk better, and to kind of roll that out across Scotland. And it's been quite successful so far, so we're funding those positions for 2 years, and we're at the beginning of those 2 years. The programme, we're also working really closely with the Scottish Cardiac Audit programme to ensure that data is collected, the programme is monitored. They're working with colleagues in Denmark as well who have a registry for sudden cardiac death and out-of-hospital cardiac arrest. They've kind of got an equivalent population size. Their data collection is really good, so we're working kind of with international colleagues to improve that. And yeah, I think that work is kind of highlighting that we realise that there is better research needed, and the BHF are committed to that. And also to say that the BHF have funded £30 million worth of research in our Cure Heart programme, so it's our biggest ever research grant through our Big Beat Challenge into finding potentially a cure for genetic cardiomyopathy, which is kind of a leading cause and leading risk factor in sudden cardiac death. So yeah, just to say that we are kind of committed to work in this space, and I've got a couple of quotes from kind of people that are involved in the inherited cardiac condition kind of pilot and how their families have been supported through the programme. So there was a family member that said, whoever had the gene related to the kind of greater risk of sudden cardiac death, regardless of how scared we were, I knew we'd be looked after. And I think that just shows that having these clinical coordinators, having these positions funded, the work by the Scottish Government, the work by the BHF, is having real impact on people's families. Like, I realise this is understandably a really emotional and really important topic, and I think it's really great to see that there is kind of on-the-ground support for people that are going through bereavement, they're going through grief, but they're being supported kind of through the whole process, and they're kind of not being left to kind of signpost themselves to services.
Okay, thank you. Just the second and only further question I have really is whether you are able to comment on this question, which is, what do you believe would improve data collection and analysis to inform screening and prevention strategies? Are there any particular, I think two of you have referred to gaps, and are there any particular steps which you would advocate, or areas where you feel there are gaps that need to be filled in order to improve data collection, in order to inform screening? I'm thinking in particular of young people here. That's the topic of this particular petition.
So I think joining up the data is one of the challenges. Dealing with these tragic cases, there's many agencies that become involved. Where patients survive, you have almost a pathway to be able to provide that follow-up. Where tragically the patient dies, it's then how we pull all the agencies together to make sure we get that data, and we can then fill those gaps in order to ensure that we make all the extra testing that then goes around for other family members, as an example, available to everyone. And I think certainly the work that's happening in the west of Scotland is this is where we're learning lots about this data gathering and joining up of data between different agencies to help improve those gaps.
Just to agree and say that I think the continuation of work like that, of pilots like that, and kind of rolling that out Scotland-wide will hopefully fill some of those data gaps. And the kind of work going forward with colleagues in Denmark and the Scottish Cardiac Audit Programme, we would hope that kind of as the pilot is rolled out across Scotland, we're only going to get better data, we're only going to get better evidence around that particular issue. And just to say that, yeah, we hope that work will continue, and the data that we get from that will kind of inform our policy.
Thank you very much. Thank you.
So can I ask a couple of follow-up questions? So just to understand the pilot, and you're talking about the rolling out of the pilot, what is the status of that currently? Is it still just a pilot, or has it started to roll out?
It has been started to roll out. So it's being rolled out across Scotland through those 2 clinical coordinators that the BHF have funded. So
right.
it is being rolled out.
And do you know if there's a timeline? I mean, when would you expect it to have rolled out?
I don't have an exact answer for that at the moment, but we're very happy to write to the clerks after.
And my second question really is on this issue of data and the government's out-of-hospital cardiac arrest strategy document 21 to 25. There is a paragraph in that where it says that it doesn't address cardiac arrests in children or those caused by external physical injury. It states that both of these types of cardiac arrest are far less common than those caused by medical conditions in adults and require a different approach to their management. Now, given that the strategy document was written at a certain point and data is emerging and being collected, does the data continue to support that view, that it is far less common that there is still not a necessity potentially to look at children per se, or cardiac arrests arresting out of physical injury, which of course was potentially one of the issues underlying one of the petitions we're considering?
So I'll come in here. So of course we report on children as part of the annual report in terms of the data available, and through all the other measures that are throughout the report. But work that happens separately round about child death is within Scotland, run by Healthcare Improvement Scotland. There is a review into every death of every child in Scotland, so a multi-agency review, and we take learning from those deaths, from that piece of work that's happening, coordinated by Healthcare Improvement Scotland. So it's not that we don't do any work to improve cardiac arrest in children and young people. There's lots of work going on, right. But it's just the way the data is reported and the processes are slightly different. And that's often because there's different causes of those cardiac arrests and different treatment options, but also you will find themes within death in children, which we, through Healthcare Improvement Scotland, can then be picked up in terms of public awareness, for example.
Thank you. So essentially, the area of data gathering isn't ignored, it's just it's gathered through a different kind of collective mechanism.
Yeah.
Okay, thank you. David Torrance is going to take us through the second section. David.
Thank you, Convener. Good morning to witnesses. Petition 2067 has highlighted issues around public awareness and education around cardiac arrest. sudden cardiac death and inherited cardiac conditions. How can the public understanding and awareness of cardiac emergency be improved? Who's going to go first?
Happy to jump in there. Look, it's a really important topic, and in some respects it's a good news story in Scotland. Over the last decade, we've made massive improvements in terms of survival from cardiac arrest, and a huge part of that is as a result of the public awareness raising and training that's been provided through the Save a Life for Scotland partnership. If you go back to a decade ago, in the region of 45% of all cardiac arrests had bystander CPR, which is poor and low. That improvement work has seen it reaching closer to 70%. Survival, 30-day survival from out-of-hospital cardiac arrest has doubled. But I think that there's still work to be done. And actually, Denmark's already been mentioned here. And if you use some of the examples from Denmark, we know we can probably improve further. And we know there is still large swathes of the population that don't still have awareness, whether it's awareness of cardiac conditions, awareness of how to perform bystander CPR and use a publicly available defibrillator. So what more can be done? Well, this is exactly the work that the Save a Life for Scotland partnership is doing, and as well as their business as usual activities, for want of a better way to put it, so all the work they've done throughout this last decade, we're also now, and have been for some time, proactively looking for and reaching out to more difficult to reach communities as well. So that we can make sure that there's this equitable response to cardiac arrest right across the country. Because the best care happens in the community before the ambulance service arrive. These individuals, it's an immediately life-threatening emergency, and they need the public to intervene to help save their life. So yeah, it's through that partnership working through the Save a Life Scotland partnership that the vast amount of this work is being done. And we've seen improvement, but we still feel there's more to do.
Anybody else?
I would agree as well. I think the Save a Life for Scotland partnership is doing really incredible work in this space, and I think from the BHF's perspective, we obviously work a lot on kind of CPR training as well. So we have Reviver, which is a kind of free, accessible online tool to teach as many people kind of CPR as possible. It only takes 15 minutes, and the kind of idea of kind of all these kind of different ways to learn CPR is to make it accessible, to make it normalised. We just rolled out Classroom Reviver as well. I think the idea is to kind of socialise the idea of doing CPR, being aware of CPR, knowing how to use a defibrillator, knowing where your nearest defibrillator is, knowing if your community has one. Mine's on my road. Is it at your local church? Is it at the school? Is it at a few streets over? Kind of encouraging people to kind of be aware of their own communities, be aware of their kind of environments, but also recognising that there are places in Scotland that are kind of underserved in terms of defibrillator access, in terms of kind of CPR training, and recognising that there's a bit more work to do to kind of make sure that those communities are kind of CPR ready, they are ready to kind of support anybody that does experience a cardiac arrest.
And Maurice Gold's going to explore those themes slightly further shortly.
Kirsty.
Yeah, we agree with our colleagues there. I think we have made advances in Scotland for the Save a Life partnership and the out-of-hospital cardiac arrest action plan. The data does show that. Obviously, we need to go further. And it's something that we have been discussing with colleagues internationally as well at Chest, Heart and Stroke Scotland. We are one of the leading partners on the bystander service that is part of the OCA plan, which provides aftercare for people who witness or provide CPR to people in a cardiac arrest. It's a traumatic event. I think we can all recognise that. And they're part of the challenge is ensuring people know the full chain of support they can have. They need to know how to be able to do CPR. They need to know they're going to be supported afterwards as well in that moment. So we held a symposium with colleagues from Scandinavian countries and others that are doing work in the aftercare. It was around recovering after a cardiac event earlier this year. We're going to make that an annual event to explore that. And one of the outcomes of that came is we do need to look at now how we spread awareness of the good offering we have in Scotland. We've had over 200 people come through our bystander service so far, where they can call, they can get ongoing support, which for running for 2 years is good. We're happy and it's picking up pace, but we know that more people can benefit from that. So we hope that the next iteration of a strategy in Scotland will continue to look at what we're doing well, but also how do we communicate that through population.
Stephen.
Sorry, may I come back in as well? Of course, the other group that it's incredibly important for us to target in terms of raising awareness is the amazing young people in Scotland. So It's well recognised that CPR training in schools has lots of benefit, not least because kids don't forget stuff. So, you know, 20 years down the line, guidelines may have changed, but children and young people will still remember what they were trained in school 20 years ago. But also, they have a huge multiplier effect. You may be aware we had an amazing Restart a Heart Live just a couple of weeks ago, where we spent 12 hours live streaming training out to whoever who wanted to see it, but it was targeted at schools and young people, and 132,000 people, albeit from all across the UK, tuned into Restart a Heart Live, which was an amazing thing. But it's the multiplier effect. You know, when kids do things like this, they don't just learn themselves. They go home, they grab their teddies off the bed, or they stick a coat in a pillowcase, and they show everyone else round about them how to do chest compressions and actually make people more aware of defibrillators as well. So it's a hugely important piece of the jigsaw when it comes to awareness raising.
Quickly jump in, and please do stop me if I'm jumping ahead. On the kind of issue of CPR training in schools, I just want to highlight Scotland is the only nation across the UK where CPR is kind of not mandated on the curriculum, and it's not reportable. And there is kind of some evidence to suggest, and anecdotally, we kind of are kind of leaning towards the direction that actually we do need to make it mandatory for schools to train every child in CPR skills. And it's that kind of thing of we need to normalise it, like using a fire extinguisher is normalised, like knowing where your nearest fire exit is. It needs to become a kind of more socialised, more normalised kind of part of growing up as a kid, knowing how to do CPR, being confident in how to do it. And at the moment, the picture is quite unclear in Scotland, and it's really, really hard to gather data about how many kids in Scotland are being taught CPR, when they're being taught CPR, how they're being taught CPR training and skills. And we do think that there's maybe a little bit of kind of inequality going on about we don't know what is going on, and if it were to be made mandatory and it were to be made reportable, it would be a lot easier for kind of organisations like us, for SALFs, to monitor how many people in Scotland have CPR training skills, and we would hope that that would be quite strongly reflected in the kind of bystander CPR rates, and also just kind of socialising this as a norm kind of in our society as well. So yeah, something to consider.
And actually, thank you. I'll come back to that shortly in the questions I have, because that follows on from one of them.
I was just thinking about, I run a scout group and how effective they are at doing CPR and first aid and things like that, and it stays with them for the rest of their life, Stephen, so I would probably agree with that. But we touched on it earlier. How effective are the Scottish Government campaigns in reaching, and how inclusive are they in reaching these diverse communities out there?
So I don't know the answer to that directly in terms of how effective we are. I think what they do help is raise awareness, not just amongst the whole population, but also amongst those people that are trying to do work within those campaigns. And I think that's important, because it gives validity and support to what we're trying to achieve. So if we're trying to reach out to the homeless communities in Scotland so that they're as likely to get bystander CPR, you know, if they need it as any other community, then you know, having that Scottish Government buy-in to the out-of-hospital cardiac arrest, I think, is hugely valuable and very welcome for the whole Save a Life Scotland partnership.
Yeah, and just to add to that, I don't have the answer as well. It'd be really interesting to know if there has been any evaluation so far on that. But we do know there are certain groups that are less likely to receive CPR training. I've received it at work, and through voluntary schemes. So people who are no longer working, you know, and they're not keeping those skills live. As Kim has just said, we don't know what's happening in schools. We have that commitment, but I know the Parliament just heard a very moving speech from a young man, Cameron Magar, I believe his name, a couple of weeks ago, you know, who lost both his parents and didn't know CPR. So we know that's an issue there. So there is more to be done, and I think looking at the communities where it can be socialised well and also are not going to receive that elsewhere is key. And a key message that's come out of some of the discussions we've had is people are scared they can do something wrong. Doing something is better than doing nothing, and that's a really easy message, I think, to get behind, but we're not seeing it out there as much. I think we can all collectively agree within the sector that that is worthwhile getting behind. It's just how we do that.
No further questions.
Okay, David, thank you very much. So we're going to move on now to the provision of life-saving equipment and emergency preparedness, and Maurice Golden is going to take us through this section.
Thank you, Convener. So petitions PE 1989 and PE 2101 both call for increased availability of defibrillators. Now, if we park funding for the moment, that will be my final question. But in terms of availability, I wonder if you could provide some information on how defibs are mapped, and also in terms of improving access. There's a bit of a conundrum, I suppose, between speed versus effectiveness. So an obvious quick way of rolling out defibs would say put it on the outside of every school. But I think, and I'd be interested to hear your thoughts, sometimes that could be doubling up in a community, and other times a school might not be located in the right area. So, you know, in Dundee, Grove is right in the centre, lots of houses nearby. That would be useful, but the new Green Hills High School is right on the outskirts of a community, so it might take someone a 10-minute round trip. Hopefully the ambulance would be there by that stage. So in terms of a more effective way, but perhaps longer term way of rolling that out, how would that be mapped? Where would you look at? What would the priorities be in terms of the most access, and how might that affect rural communities?
Happy to start. I think it's a really important question, and I think I want to start this by saying we've never had better data about where defibs are and where defibs should be. So on where defibs are, so the BHF created the circuit, which is the UK's national defibrillator network, and I will say the defibs that we know, and it's mapped out kind of geographically across the UK. You can go online, you can look at where your nearest defib is. The ambulance service has all of that information, so when you call 999, they can point you to where the nearest defibrillator is. The circuit can only hold defibs that are registered, and we do know there is still a problem. We can't put a figure on it, unfortunately, because we don't know how many defibs aren't registered, but it is believed in Scotland to probably be around the thousands. So the first thing is making sure that we have every available defib registered on the circuit, and that if we were to kind of expand provision of pads, that all of those pads be registered. And I will say that the amount of data that we get from the circuit, it's been around for quite a while now, it's matured, we get incredible data. So we have kind of new statistics around areas in Scotland that we know do not have enough defibrillators. And we've just got a new tool in Scotland this year called PadMap, which is being funded by the Scottish Government. And it's had involvement from the BHF, the Scottish Ambulance Service, St John's. And we've never had a better tool to be able to tell where defibs need to be in terms of kind of historic cardiac arrest incident rates, in terms of existing defibrillators, that information we get from the circuit. But they've managed to kind of mathematically optimise defib placement. So it's kind of a free online tool. You can just kind of Google PadMap, go on it on your phone, and it will show you kind of green dots, and you can break it down by local authority or postcode. It will show you where the best places in those communities are to place a pad, how many times it's expected to be deployed, how many shocks are expected to be delivered, and even an estimate on how many lives it could save. So I think PadMap combined with the circuit data that we have, and the BHF have kind of, we've identified 12 areas across Scotland who really do have really long retrieval times for defibrillators. So, you know, in Saltcoats, North Ayrshire, we're looking at 17 minutes retrieval time, which is way too long. You would really hope that an ambulance would get there before that 17 minutes retrieval time. But I think the data is showing us we have really good coverage in some areas, and we've got schemes that have been really successful. The BHF have a funded community defibrillator scheme. We've provided kind of over 400 defibs in Scotland over the last 10 years, but there is still a way to go. But the good news is that we know where they should be. And I will say all of this data is amazing, but it does need to be coupled with that kind of community support. We do need boots on the ground, making sure that communities are engaged. We do sometimes have a problem getting guardians for defibrillators to be emergency ready, to make sure that they've got replacement pads if their battery needs to be replaced. We need kind of members of the community to check on them and report that back to the circuit. So there are kind of barriers, there are obstacles. Souths are doing great work to kind of understand what those barriers and obstacles are and how we get around that. But I think in terms of where do we put DFIBs, where needs the most, and it is in those more deprived communities, we know where to put them. So kind of any commitment to a rollout, we've never been in a better position to do that.
Mm-hmm. Thanks.
Yeah. Thank you, Convener. I've seen PadMap work. Normally when a defibrillator is bought, it's usually a community organisation that buys it. And then many times, as you say, it's not in the right place. How do you get to these organisations to say, this is where it should be? Because the majority of the defibrillators out there have been bought by community organisations or youth groups or whatever. So how do we advertise it? This is, if you're buying it, this is where you should place it.
Yeah, I think better socialisation of kind of PadMap, the circuit, those tools that we have available, and making sure that there is like really robust signposting to these resources when communities, there's obviously kind of a lot of schemes and a lot of funds that community groups can apply for. I think as a sector and kind of with the Scottish Government and with the Parliament, making sure that there is really good awareness of these tools, of these maps, and also making sure that that community support is there and available for people. You know, if they do have questions about defibrillators, I think it can be quite difficult knowing who to ask. So make sure that that is joined up and that it is really robust. And I think we are getting there, and there's some really amazing work kind of being done by partners across the sector to address that. But I think we're definitely moving in a positive direction.
Can I just add to that very quickly as well? I don't think we should shy away from involving the industry in this as well. Ultimately, someone has to sell these individuals a defibrillator, and actually we have good relationships with the industry in a positive way, and that's right that we do that, because they can be incredibly powerful when it comes to signposting people to PadMap when ultimately communities are coming to them and saying we want to buy a defibrillator from you. And they're an important part of this jigsaw in many ways. And also everyone within the Souths Partnership who do a phenomenal amount of work, and some big organisations as well who support communities to place defibrillators now will always use PadMap to support those communities as well.
Just to add to that, I'd echo both comments that we're in a really unique and positive position in Scotland at the moment with PadMap. It was only launched in the summer fully. So just to give it, that's how kind of cutting edge we're at with this. There has been a pilot done in Falkirk where they have over 100 DFIBs fitted, 104. They've put about 41 in with PadMap, and the ones they've put in with PadMap, I've seen twice the level of deployment and 66% increase in the number of shocks that are delivered. So it isn't just about, I really welcome the question, it's not just about, you know, it's not how many it is where, and the data supporting that. The question about how we roll that out is now where we're at, but I think we're in a really good position as a sector and with support from Scottish Government to have those conversations, because as you've said, there does need to be community buy-in, there needs to be guardianship of DFIB still. So it's how we now utilise that data to have conversations with people of how it's going to work in their communities.
Thanks. I'll follow up on that and bring you in, Stephen. So, you know, after almost a decade in the Scottish Parliament for myself, I've certainly seen the Scottish Government on many occasions want to tackle the headline rather than tackle the problem. So you can see how appealing it would be for the government to provide public funding for DFIBs in every school in Scotland. It sounds great, but I really just want to press you a little on whether a more, which I think you've touched on, whether a more sophisticated approach is required. And yes, schools might be part of that, but other public buildings or community areas could also be appropriate. In terms of if there was public funding available from the Scottish Government, how would you see that approach being rolled out effectively to highlight and prioritise the areas that are most in need of this piece of kit?
So happy to jump in here. I think when people think about public access defibrillators, they have a picture of a pad in a cabinet on a wall somewhere, which a lot of the time it is, but they don't always work depending on the communities. And you've said two things within your questions that jumped out, which was near housing estates and in rural areas. And I think there is no question that if a member of the public attaches a defibrillator to you and delivers a shock before the ambulance service gets there, you're much, much more likely to survive. And remember, not every cardiac arrest needs a shock. You know, it's only, in Scotland, it's about a quarter of them have the type of cardiac arrest that a defibrillator will work on. But 80% of cardiac arrests happen in the home, and very often the only person with the victim of the cardiac arrest is the caller. So they are unable to leave to go and get the pad off the wall that's 200 yards down the road because they have to stay there and do chest compressions guided by our call handlers. And in more remote and rural parts of it, it's a difficult task to find places to put defibrillators that will provide coverage. And I think, so there's two things. Where pads would be effective by putting more of them into the public space, as we've alluded to, we have that data and we can support that through PadMap. But also I think the other piece of support that would be welcome would be to help us to look at other ways to get defibrillators to people, and that would be things like community cardiac responders or community first responders or other types of co-response, whether it's with emergency service partners. So where we know we've got slower ambulance response times because of the rurality of the area, then we need to try and work out how we can get people to that patient more quickly. And we've seen some quite good success, actually. I'll use Grampian as an obvious one, where we have the Sandpiper Wildcat scheme, where we have a couple of hundred community cardiac responders all over the region, and we know they get there on average 6 minutes quicker than us. They're trained and equipped by the Scottish Ambulance Service. We know they do excellent CPR because we've been able to download the metrics from the defibrillators they use and analyse that. And that's one example. And you may have seen in the BBC last week, we've now rolled out one of these community cardiac responder schemes in the Dumfries and Galloway area, which was, you know, within a few days of being live, were successfully deployed and saved a life. And again, that's a particularly rural part of that region. But we send the pad with someone to use it, rather than having the expectation that a member of the public goes and retrieves the pad from a fixed place. So the answer to improving survival and pad use isn't to necessarily flood the place with more public access defibs. It doesn't equate that will equal extra survival. What it does mean is, can we think of different ways of getting public access to defibs in areas that need that different way of doing it, and how we roll that out.
Thanks, that's very helpful. Kim?
Thanks. And yeah, just to say that a lot of these kind of communities do need that kind of nuanced approach when we do have a really rural nation. Like, how do we best serve those communities? And I think on the issue of kind of pads on schools, I just kind of want to highlight some new data that the BHF are kind of being able to produce using the circuit. We modelled what happens to the retrieval time for a defibrillator, just the average retrieval time across the whole local authority. So it's just indicative, it is covering large areas. What happens to the average retrieval time across local authorities in Scotland if we did put a registered pad on every school? And I think in some cases there is kind of a positive reduction in retrieval time. So Glasgow City, for example, the average retrieval time in Glasgow City for a defibrillator, bear in mind, very heavily populated, very densely populated area, goes from 5 minutes 12 seconds. If you put a pad on every school and register it on the circuit, that drops down to 3 minutes 48 seconds, which is kind of a marked reduction in retrieval time. And the retrieval time reduction is seen most significantly in those most deprived areas. So the reduction in retrieval time is about 25% in the most deprived communities. So I think that's an example of possibly where if we we'd need to run that data on a more kind of local, more granular level, but that putting a pad on schools could be a good solution. But I think there are other examples, kind of as Stephen's kind of mentioned, where we in those rural communities that maybe doesn't work as well, and we want to be putting kind of pads in more residential areas, and schools can be good for that. So there is some research that shows that kind of a third of out-of-hospital cardiac arrest can happen within 300 metres of a school. They're often really well located within residential areas, and it would increase the numbers of registered defibrillators from just under 10,000 to 11,730, which is a big kind of increase in the availability of defibrillators across Scotland. But I think the big thing to say is that benefit is not seen equally across all the local authorities. So Aberdeen City, for example, already have defibrillators on a lot of their schools. And in certain areas, like North Ayrshire and Renfrewshire, we only see the reduction by a few seconds. So there are reasons that it could be a good idea to put pads on schools, but I think the more nuanced approach to say schools in certain areas, maybe in Glasgow City, could be a good place, but we should use tools like PadMap. We should look at learnings from the kind of Sandpiper project and kind of pull that all together to make sure that we're not leaving certain communities behind. We're not doubling up defibs on schools that may be next to a building that already have a defibrillator, making sure that all those unregistered defibs are registered, because that might change the picture. We can rerun all this data in 6 months' time and we might have quite a different picture. But yeah, just to say that I think there is nuance kind of needed here, and to make sure the communities that need the most, we do need to be looking at kind of a combination of all this information.
Thanks for that. And just final question, really, just to cover off funding, although I think the panel has touched on this. I mean, clearly there's a number of options for Scottish Government funding. It could be, you know, taking a kind of bird's eye view and targeting that funding directly. It could be via councils. It could be via a community fund. I think the risk for me with a community fund is it's generally the most established community groups that will be applying, and there'll probably be if there was a community fund, Isle of Egg would definitely have a defibrillator if they don't already have one, because they do a fantastic job at applying. So interested in terms of if you have any thoughts on public sector funding, but also any examples that perhaps could be spread out either by linking to public funding of, you know, excellent, you know, third sector work in this area, or even private sector.
Yeah, so and there is excellent work going on in right across the sector, not least from the third sector, I have to say, who do some phenomenal work in communities right across Scotland. I think that any target in funding, I think, comes with that the nuanced approach we've been speaking about, and you know, there are definitely areas where we can identify that would benefit from having greater increase to those public access defibs in the traditional way that we think of them. Another thing we know is, you know, in the most deprived areas of Scotland, you know, these are where we're most likely to see the cardiac arrests that are most likely to respond to defibrillation. And we've seen survival right across all the, you know, indexes of deprivation in Scotland, but the gap's getting wider. You know, it's not climbing as quickly in the more deprived areas. And that's often because, whilst these individuals are probably just as likely now to get bystander CPR, they're not just as likely to be defibrillated. If you're in a kind of higher, a lower deprivation score. So looking for those types of areas within those communities and funding defibrillators is a win, but it also needs to come with the resource that's required to raise that community awareness. And I think that's the key bit to pads. If you stick it on a wall, and you know, speak to any one of my colleagues, and they'll have been at cardiac arrest within eyesight of a pad that's not been used, that's still sitting in the case, which is soul destroying, I have to say. So it's the community engagement that comes with the placement of that pad that I think is important. So funding to support that kind of stuff is just as important for funding for pads in areas of need. And also, if you look at examples of taking the pad to the patient, it's quite a resource-heavy operation. Setting up and training and equipping a cardiac responder scheme, for example, takes resource, and I think funding in that space would be beneficial and help, particularly those more remote and rural communities as well.
Thanks.
Yeah, and just to add to that, I think the two areas that my colleagues have identified in terms of areas of deprivation and rural areas, we've got two quite nuanced approaches we can take here. You know, studies have shown that in Scotland, if you're in the most deprived area, you're over 300 metres further to a 24/7 access defib than you are in your least. Now, to compare that to, you know, England, that's only 90 metres. So we do have a huge issue here. But we know that, and we know the areas now. We've got the data. I think, yeah, it's a cross-sector approach. I think the third sector can play a role in bridging that gap between the communities that need them but might not apply for these funds, as you say, and raising that awareness, as you know, as Stephen's just said, in use. So I think, yeah, the model, we've used the model, you know, BHF have got their funds and we see there is success there, but we need something additional along with looking at the areas that might need a different approach. And I would just commend the work that we've just hired Stephen describing around the wildcats and in Dumfries Galloway. Like the data is showing in Grampian that we are seeing a change there because of that. So I think public funding to take a strategic approach, and partners want to be around the table. I think you can see that today. To have that be part of the solution, people have been bought in to that already.
Thanks.
Yeah, just to agree with my colleagues and just to add that, like, just to highlight that Scotland is the only nation that haven't kind of committed investment to DFIBs in England, Northern Ireland and Wales. That's been on schools, but we do kind of have an opportunity here to invest really effectively and really strategically. It could be on schools, but as we've heard, there are many other ways to do this. And I guess just to highlight that we really welcome that investment. I think it is needed. I think we are seeing quite marked inequalities in this space, but I think we also have an opportunity here to reduce those inequalities and have a real impact here on survival, particularly in those kind of areas of deprivation, those communities of greatest need. We've taken that more targeted approach with our funded DFIB scheme at the BHF this year, kind of using data to make sure that we're kind of actively targeting those areas specifically in those communities that need them most. So just to encourage kind of the use of any investment to be targeted where it is needed most, to be in those areas that need the most. And I guess the good news is we know where those areas are now.
Thank you, panel. Back to you.
Thank you. Interestingly, just before we went into recess, the October recess, at the last conveners group, I was able to raise these issues arising from these petitions directly with the First Minister. Now, there were two or three that follow on from the conversation we're having just now. I just thought I'd refer back to. I mean, he obviously was paying tribute to the work that's been done in terms of rollout, was keen to explore if there's anything more the Scottish Government can do to give impetus to the partnership, and he's asked for feedback on that. He doesn't himself see a role for the public sector in defibrillator rollout, which is, I think, where there is a distinction between some other parts of the United Kingdom or all other parts of the United Kingdom and Scotland, and that arose in a response we got from the Minister Jenny Minto at an earlier point as well. However, relating to the public access map, it does actually show serious clusters of non-availability. I noticed that Glasgow in the west of Scotland actually was particularly the case in that regard. And he said he's asked for proposals to be submitted to him because that is something the Scottish Government and he has now taken a particular interest in addressing. And I suppose following on from that, and I was listening carefully to everything that was being said, the last kind of list of numbers we've got from 23-24 showed the number of pads at 8,723. I mean, this will have advanced a bit, I imagine, since, which was tripling of the number since 2019, which is excellent. But what it did also show was that the deployment of those defibrillators, and I think you said it's sad to see in a nice shiny case on the wall, one that's not been deployed. And I suppose this comes slightly back to the question Maurice Golden was asking is, are we confident they're going in the right places? And are we confident that the training of how to use them is following the actual supply of the installation?
A graded approach to this work over the last decade, and actually during the very first out-of-hospital cardiac arrest strategy there was a conscious decision to focus more on bystander CPR rather than CPR and defibrillation, and that's because our bystander CPR rates were so poor. And so the first 5 years of the strategy it was very much the focus on let's not focus as much on defibs because we need to get people pressing up and down on cardiac arrest victims' chests first and foremost. Yeah. The last 5 years that's changed completely, and we now have this much greater push about CPR and use of a defibrillator. Are we confident they're in the right place? Well, I think we can say some places they are, but we've still got that work to do, as we've highlighted. So, you know, and when you talk about Glasgow and the west of Scotland, you know, the highest rates of shockable cardiac arrest, so the types of cardiac arrests that defibrillators work on, are in our deprived urban areas, and they happen most commonly in our service industry workforce. It's you know, predominantly males and predominantly males who are in their 50s who go into shockable cardiac arrests. Yet they're the ones that are not close enough to the defibrillator as Kim has described. So I think we can be confident in saying they're not always in the right place yet, despite the amazing work that's been happening, and we need to find those areas and put them in.
And given that in other parts of the United Kingdom there are government-led initiatives to provide, and in Scotland we are still largely relying upon charitable organisations and voluntary community initiatives, is that going to plug that gap in that access map in Glasgow and the west of Scotland, in some areas where I imagine the likely availability of fundraising initiatives to try and address those deficiencies are going to materialise?
So the funding to provide pads to plug those gaps would be the easy part. The challenging part then is finding the guardians in the communities who can maintain the defibrillators, check the defibrillators, be responsible for changing batteries when they run out over a several-year period and all these kind of things. So funding and placement, I think, is a relatively easy thing to achieve. It's then the community part of it that's the difficult bit to achieve round about it, both in terms of guardianship and raising the awareness in the community, which is a key part of those pads.
Okay. Thank you. I mean, I'm just exploring some of the themes from the fourth of the questions, which is the one I'm leading on preventative actions and protection of vulnerable populations. And I was struck by something you said earlier on, and I just, at my own expense, want to just understand. And that is that, we've done a terrific job with children in schools. You teach them these skills and they still have them for, 20 years later, they know what they're doing. MSPs were all sent on training for CPR. I remember it upstairs in Queensberry House. I can't remember a blessed thing about it. Now, is that a reflection of my senility impending? Is it that the older you are, actually, in not deploying a skill that you've... I mean, we were all quite good at it by the time we left the room, but 5 or 6 years later, having never been in a situation where I've had to deploy it, unlike those children you were talking about who are taught the skill at school and 20 years later can still walk right into doing the correct actions, is it just me, or is it the case that that these skills are best absorbed at an early age because they will last longer, and that it's harder actually to retain these skills in an older age group?
It suddenly feels like the first question. I'm under pressure. Look, so we know, absolutely, in adult learning, we know we forget stuff. And skills decay of any skill we perform. If you don't keep performing it, then your memory of that skill will decay. And it decays relatively quickly. However, whilst acknowledging you say you don't remember it, and you probably don't, you still have had training and awareness of it. So when our call handler, who now supports you through telephone CPR advice, starts to say to you, kneel next to the patient, there'll be a little bit of something in there that goes, oh, I need to kneel next to the patient beside their chest, and I need to put my hands in the centre of the chest. That's right. And so it's a multimodal approach almost, where you've had awareness and you may feel like you've forgotten it, but actually you will get those prompts will trigger your memory when you're speaking to the call handler.
So, in essence, those prompts in a situation where it might have to be deployed, that is okay, rather than a continuous programme of refreshment in terms of...
Look, any clinical skill, we would always like, we would want, and we expect our clinicians to do refreshers of skills that they use. And that goes right across any skill. If you look at our colleagues in the fire service, you drive past any fire station and you see firefighters out training all the time, and that's so they're practising the skills they know, so that when they have to use them in reality, it becomes a much more automatic thing. I think that's difficult to achieve in an entire population, having an expectation of the communities that they have to train all the time. Okay. But the more people get exposed to these types of skills, God forbid they have to use them, the more confident they will feel. And I think that's the important word when it comes to performing CPR for members of the public. It's not about competence, it's about confidence to have a go. And, we've already spoken about harm, and that's often the biggest fear. So the training and awareness can allay some of those anxieties that people may have.
Okay, thanks. I wanted to touch on an issue that came out of Sharon Duncan, David Hill's mother, in relation to evidence that we were then able to obtain from the Consulate General of Italy, where for a very long time now they've had a screening programme for young people actively engaged in sport up to the age of 35. And the evidence from there has suggested an 89% reduction in sudden cardiac death as a consequence, 89% reduction as a consequence of that. And it brings me to this whole, I suppose, the generic question about preventative care versus reactionary care, in that, you know, the simple kind of prejudice sometimes you feel that lies above all of this is that preventative care is a cost up front that you don't see the benefit of, whereas they'd rather deploy things where the accountants can see the return. And when you look at something like that kind of statistic of evidence in terms of the reduction, and obviously particularly poignant for the Hill family, given David's death, I mean, is there more we should be learning or prepared to embrace when it comes to preventative initiatives? I know my colleague Brian Whittle raises this across almost all areas of health within the chamber of the Parliament, that preventative action and being willing to be more open-minded about the potential issues arising from all of this, would it make a difference, particularly when you see, on the other hand, that we don't have a particular strategy, the government, to tackle this particular area?
I can come in that. Yeah, as an organisation, Chest, Heart and Stroke Scotland has been calling for prevention as well. We've had conversations with Brian and many other of your colleagues around this, and it's been nice to see recently a bit of a shift in understanding that we can't continue just to plug the gaps and focus on the key metrics we all see in the media around waiting times and hospital beds. That's really important, but we're going down a direction. Studies show economically, if we even ignore the tragic human impact of not focusing on prevention, we can't sustain it. I mean, the state of healthy life expectancy in Scotland is scary for us all. It's that nuanced approach, though, to what is prevention and the different stages of prevention. The Italian study is compelling. And what I'd love to know more is, once they do that screening, what are the next stages of that? Because I think that is something we saw from the National Screening Committee, that we need pathways for people. There's different levels of prevention. You know, we've got that population level around eating well, looking after yourself. A lot of the cases we're talking about in sudden cardiac death in young people are genetic. They're not going to be prevented from occurring. So when they're detected, it's what are the next steps of that pathway. So I think it's really compelling, and I think it'd be good to have more conversations around pathway development for that.
Thank you. Kim, you touched earlier on schools and the fact that it's not an integral part of the kind of curriculum in terms of the requirement. I think it was also the case that when we got evidence that had been submitted, some local authorities didn't contribute, so we weren't altogether clear what actually was happening. And I just would like you just to touch a little bit further on what difference you think it would make, and where within, at what age group, how would that happen in terms of making it slightly more complex? Is there a best practice model that actually could be articulated as being something that should become a more compulsorily established requirement? And I suppose if I could ask just you and maybe others to expand beyond that, what are the standards of guidance in workplace settings? I mean, is it up to, I mean, is there a national standard in terms of how workplace training and understanding of these issues should apply? And is there a best practice guide there, or should more action be being taken in that regard as well?
I think firstly, to touch on the kind of issue of schools, I think it's quite difficult to kind of create a best practice model without kind of having the data available to us to kind of model what that looks like at the moment. I do want to acknowledge that all the local authorities in Scotland did commit to kind of teaching all secondary school students in Scotland CPR, but I think, as you say, we don't really know what the picture is and the landscape is at the moment. And I know that ourselves and partners in this space are committed to finding out you know, if we do want to make this mandatory and we do want to make this reportable, how do we design this kind of in collaboration with colleagues in education to make it as effective as possible? And it might be that it's taught in 1 year and then you get a refresher course a couple of years down the line. So I don't have specifics at the moment about what that specific kind of rollout would look like, but we are committed to working across the sector to make sure that if that were put in place, it would be really robust. And we've got colleagues in England currently at the moment, because it is on the curriculum, looking at what does a monitoring system look like, what could that look like, what information do we get from that, what can we learn from that. But I think it is a really important issue, and as Stephen said, like when you learn those skills as a young person, they do become a lot more normalised. You carry them with you for the rest of your life, and you're probably more likely to kind of do that refresher course. And it is a little bit like I've done first aid training at work. We get something, a refresher course every year. Like it just becomes a kind of normal part of life, and that's really, really important. Kind of breaking down those barriers about people thinking they're going to do harm by performing CPR and being quite unwilling to do it, especially if it's an older person or a frail person. And also there's still misconceptions around, you know, I need training to use a defibrillator. People don't need training to use a defibrillator. Defibrillators kind of speak to you, cooperators speak to you on how to use this equipment. So I think there's still work to be done, but I think there's a real opportunity there, and I think there are kind of examples, and from memory I think it is Denmark, where CPR training is mandatory and it is reportable in schools, and they do have higher survival rates. So it is an interesting kind of question that we really want to dig a little bit further into, and I think it is an issue at the moment that we don't understand the landscape around CPR training in schools at the moment.
Okay, thank you. And does anybody have any thoughts about the workplace sort of standards?
So to answer your question, I don't know what the standards or the legislation would say. I don't, and I've never run a business, but I know that, you know, there is a first aid at work programme, for example. There are initiatives to encourage workplaces to take up CPR training and defibrillator training, for example. So SALFs have recently collaborated with the whole partnership with the Resuscitation Council with their Resus Ready campaign would be one thing. So it's almost like a rubber stamp to say, yeah, your business is Resus Ready if you've trained a certain volume of individuals within your workplace. So there is things out there to encourage to do it, but in terms of what workplaces have to do, I don't know the answer.
All right, thank you. Our final themed section is from Davy Rossum.
It's about cross-sectorial policy, basically between health, education and other stakeholders. What are the key barriers to cross-sector collaboration between health and education in Scotland, and how might these be addressed through initiatives like the Scottish Government's Population Health Framework?
Yeah, important question, an interesting question. And actually, I was in a meeting last Monday having these very discussions, and I think when it comes to the kind of CPR training aspect of it, I think through some great works with colleagues from SG, we realise we need to, what in health work as imagined is, and what in education is achievable. I think we probably haven't understood each other as well as we probably could or should have over the previous years. And I think now what we're looking to do to break down some of those barriers is actually have some joined up thinking between health and education to say, from a health point of view, this is what we think needs to be done. From an education point of view, how can we achieve that and ensure that it is done? And also there's other partners in that as well. So education, obviously that goes right down to local authority, and what works in one local authority, as we know, isn't necessarily going to work in another one. And we're doing a little bit of a feasibility study just now with Dumfries and Galloway, which tries to join up a lot of this work. So it's looking at different levers to a local level, using, you know, a sort of assets-based approach where we know there's assets there already. How can we join up to improve things like CPR awareness in schools, communities, you know, optimising that pad placement that we've spoken about, and also how we can better get pads to people through cardiac responders or people signing up to the Good Sam app. So we're proactively doing work in that space to try and make sure we can join it up better between different parts of the system.
And just to add to that, I think there is something we've been calling for ahead in the next election is for different public bodies, and I guess descending through that, different policy areas to see their role in health creation. And I think the population health framework that you mentioned is a starting point for that, that it's not just the health policy sector, health charities that have a role to play in that. We all do in terms of prevention, and that is a shift. And it's a conversation to have as well. You know, we all know the stories of teachers and their workload and what that's like. So we need to kind of move away, I think, just from that simple to that conversation through different sectors as well. And the third sector definitely has a role to play in that. They're able to come in often and bring different angles of policy together.
I agree with my colleagues. They covered it wonderfully. And just to add that we really welcome collaboration between kind of health colleagues and education colleagues. I think, especially on the kind of issue with CPR training in schools, there needs to be kind of collaboration and co-design of what that looks like for it to work for everyone. So, yeah, we're very committed to working in that space too.
Okay. How do community planning partnerships contribute to aligning health and educational priorities locally, and what opportunities exist to strengthen collaboration across health, education and community sectors?
This is exactly the work we're exploring through the Dumfries and Galloway Care Zones feasibility study we're doing just now. And I think, so, you know, from a health point of view, health boards know lots about the health metrics of their communities, but actually the local authority knows their communities. So if we try to take, you know, Stephen Short from the ambulance service could say, you need a defibrillator there. That's a really simple thing for Stephen Short from the ambulance service to say. But actually, the local authority know who to tap into within their community through all their community partnerships to say, look, we think you need this there. Who in the community can support this? And I think this is one of the big pieces of learning we're taking from the sort of pilot that we're right in the middle of at this point. But that joined up collaboration and thinking, I think, is hugely important when it comes to what happens locally on the ground.
Yeah. I've got something else here that it kind of links in with the collaboration. You seem to be, the funding seems to be going fine. You've got the right place, you've got the data, you've got the info, you're working hard on that. Community and public awareness and training all seem to go hand in hand. And you vaguely touched in it away at the start about maintenance and replacement of faulty equipment. You know, inspection and maintenance seems to be a bit haphazard. You know, you're putting a lot of efforts into, you know, all the big parts of this. However, you know, as equipment gets older, then even if only 1% of them fail, you know, that it's quite a significant amount. And I was just wondering where the coordination was in all this for that part.
Yeah, it's a huge challenge, and it's a real challenge. And I think ultimately, there's a guardian that owns that defibrillator, is responsible for that defibrillator, whatever way you want to put it. And ultimately, the responsibility lies with them to make sure that piece of kit's rescue ready. You know, they buy the kit in good faith, they register it on the circuit so that our call handlers can signpost people to go and get it when someone's having a cardiac arrest. But then when that happens, those pads need replaced, and they're expensive. Pads as in the pads you stick to the chest, not the public access defib pad. They're expensive. So often the guardians of the communities it's not that they forget about that, but they don't necessarily factor it in because it's just not in the thought process at that point. So again, there's an awareness raising piece there. Whilst the defibs are designed to be left alone, they do their own self-checks and all that kind of stuff, the batteries still have a finite life in them. Anything between kind of 3 and 5 years is pretty much the standard now. So again, those batteries ultimately will decay over time, even if not used, and will need replaced. And again, that's another cost. But also, there's time commitment as well. So for the defibs to stay in the circuit, someone needs to go around periodically and confirm that it's still rescue ready, because the last thing we want to do is to send a bystander to a defib cabinet and either find that it's missing, or that their pads are missing, or it's not working. So yeah, it's a real challenge for us. And as the people who are not the owners of the defibrillator, I guess our responsibility within the ambulance service is to continue to try raising that awareness of some of these challenges.
It just seems a weak part in the whole
chain,
because you're working really hard.
Yeah. And look, we've got some amazing partners out there that do brilliant work in this space, and we've got some fairly large guardians of defibrillators in terms of they will manage multiple public access defibrillators in their area, and actually as a group they come together. So you've probably heard of and aware of the work of PAD Scotland. So PAD Scotland is a bit of an offshoot from Save a Life for Scotland. They're all SALV's partners, but also they specifically have their own working group that explores some of these challenges.
I was just thinking down the lines of, like, just to help you here, that, you know, like if you've got fire extinguishers, a company comes round, depending on where it is, every year or every 2 years, and gives them a wee check, and just something like that.
Stuff like that. Yeah, absolutely.
But, as I say, it's how you tie that in.
Yeah.
And I think just to add that we really encourage, if that is to be kind of investment to increasing pad access across Scotland, that it takes those maintenance costs into consideration, and maybe for about 10 years. And we've got figures around kind of like how much that would cost, but we think it is a really important part of kind of making sure that the longevity of any pads that are funded is for as long as possible, that we have the guardians in place, we have the community buy-in, the community engagement to make sure that those pads are going to be used, they're known to the local community, and that, you know, we've heard from kind of community groups and fundraisers before that they've been left in a position where, you know, they're kind of out of pocket when they do need to replace the pads, replace the battery. And you're right, it's not a cost that everybody knows about. So making sure that there's really good communication and really good expectations of, you know, where that maintenance cost comes from. And I hope that it would be considered kind of within any investment made towards pad access.
Thank you.
Thank you very much. We've run over quite a little bit from our scheduled time, but that's been fascinating and productive discussion. These issues arising from these petitions have been ones that the committee has been quite actively engaged during the course of the Parliament for a variety of reasons, and therefore they're very important. So I'm very grateful for everything you've been able to contribute to our discussion this morning, and I'm now going to suspend just briefly before we move on to the next item. Thank you again. And I'd just like to highlight to those who are joining us this morning, who might be watching online, that we now have really a very considerable number of open petitions and not long to consider them. We only have 8 remaining meetings of the committee before the dissolution of the Parliament. So our focus for the rest of this Parliament is now on identifying areas where we think we can make real progress in relation to a petition in the limited time remaining to us. The first of the petitions we're considering again this morning is Petition 1953, the review of education support staff roles lodged by Rosin Taylor Young, and it calls on the Scottish Parliament to urge the Scottish Government to review education support staff roles in order to consider urgently raising wages for education support staff across primary and secondary sectors to £26,000 per annum, to increasing the hours of the working day for educational support staff from 27.5 to 35 hours, and to allowing the ESS to work on personal learning plans with teachers taking part in multi-agency meetings, requiring the ESS to register with the Scottish Social Services Council and paying ES staff monthly. And we last considered this petition recently in March, when we agreed to write to the Cabinet Secretary for Education and Skills. That response highlights the guidance in supporting children and young people with healthcare needs in schools, and states that NHS boards and education authorities should work collaboratively to ensure that all staff receive appropriate training. Regarding pay for support staff, the Cabinet Secretary states that the Scottish Government has no formal role in setting the pay or terms and conditions of non-teaching school staff. And the submission highlights the Scottish Government's funding to support pupils with complex additional support needs, which includes an allocation for local and national programmes to support the recruitment and retention of the ASN workforce. So, in view of the response we've received from the Cabinet Secretary, do colleagues have any suggestions as to how we might proceed? David Torrance.
Thank you, Convener. In considering the Cabinet Secretary's response, and I would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Public Audit Committee recently undertook scrutiny of additional support for learning in the context of the Auditor General of Scotland's report. The committee has explored the issue raised in the petition and is limited in time remaining in the session to progress the issues further. In closing the petition, the committee could suggest to a petitioner that she raises the issues with one of her local MSPs and advises that a new petition could be resubmitted in the next parliamentary session.
Thank you, Mr Torrance. And that, of course, is advice that might be generally applied in a number of different occasions. Our colleagues, any alternative suggestions, Mr Torrance, or are we content to proceed to close the petition on that basis? We are. We thank the petitioner very much for raising the issue, but clearly there's just no time for us to adequately pursue the petition in the balance of this session. Petition number 1999 to fully implement the UN Convention on the Rights of Persons with Disabilities, lodged by William Hunter Watson, and through a slight undermining of our normal procedures, I'm afraid we haven't considered this petition in committee since the 20th of December 2023. At that time, we agreed to write to the Scottish Government. The then Minister for Social Care, Mental Wellbeing and Sport, Mary Todd, stated in her response that the Scottish Government is prioritising work to consider possible reform to the Adults with Incapacity Scotland Act 2000, and highlighted the intention to introduce a new human rights bill. Now, the committee has received a written submission from Barry Gale, who states that while the Minister's response does outline a broad vision for change, the level of impact will depend on the details of how this vision is implemented. His submission also emphasises the importance of reforming the law to put people unequivocally in control of decision-making about their own lives. Now, the petitioner's written submission makes a specific point about care for elderly people. His submission states that the Minister failed to indicate whether the programme of reform would end the giving of sedatives to elderly care home residents, and the petitioner states that mental health law in Scotland cannot be compatible with international human rights if it permits potentially harmful drugs being given to care home residents for the convenience of staff. We have a recent update from the Scottish Government, which states its intention to bring forward an Adults with Incapacity Bill and a new Human Rights Bill in the next parliamentary session, subject to, obviously, the outcome of the election. The Human Rights Bill would give domestic legal effect to a range of internationally recognised human rights, including the International Covenant on Economic, Social and Cultural Rights and the UN Convention on the Rights of Persons with Disabilities. Now, this bill would also aim to support rights holders, including disabled people, to access remedy where their rights are not upheld and establish a multi-institutional model of human rights accountability in Scotland. The submission highlights the Scottish Government has now progressed or completed the majority of the actions and milestones set out in the initial delivery plan for the Mental Health and Capacity Reform Programme. And the Scottish Government also notes that the Adults and with Incapacity Expert Working Group continues to meet on a monthly basis and is taking forward the detailed development work required to modernise this legislation. So, in fact, quite a comprehensive series of commitments going forward or actions underway. Colleagues, do anybody, Mr Torrance.
Thank you, Convener. In light of a response from the Scottish Government and actions it's taken, I wonder if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government intends to bring forward a human rights bill in the next Parliament session, which will give domestic legal effect to a UN Convention on the rights of a person with disabilities. Work on the mental health and capacity reform programme has begun, with a majority of actions progressed or completed. An adult with incapacity expert working group meets on a monthly basis and is taking forward detailed development work to modernise existing legislation.
Thank you, Mr Torrance. I'll identify 3 points. Mr Ewing.
I think there's no alternative really but to close the petition. I say so because it's plain that we're not really going to see any further specific action by the Scottish Government before recess. I mean, that's just as crystal clear. But I did just want to say, though, that a few things. I was going to pick up on the fact that you pointed out, Convener, that Mr Gale, I think, pointed out that there's a particular concern about the issue of sedatives to people in old folks' homes to make them easier to deal with. And that point hasn't been answered at all, not at all. And I thought it only fair to Mr Gale and petitioner just to point out, nor really has the petitioner's ask ever been directly responded to. And the petition was 5th January 23. The aim was treatment for mental disorders without consent should not be permitted. Now, looking back at Marie Todd's first response on 29th January 24, she didn't answer that at all, not in the slightest way. She did say that there would be the Human Rights Bill. The Scottish Government will introduce the Human Rights Bill later this year. Well, that hasn't happened. And I think it's only fair to the petitioner to point that out and just get it on the record that that promise has been plainly broken. And you know, I do think this is we're not going to get any further. But I do think it's symptomatic of the approach of the government, which is that where they're not willing to do something that they're being asked to do, instead of just saying, well, we're not going to do that because, which I suspect is the case, we get huge amounts of material, written material response, which doesn't directly bear to the point. And I personally feel that that doesn't really do the government any good at all, because understandably petitioners just get completely hacked off. That the thing they're asking for has not actually been answered at all. So I just wanted to put that in the record, Convener, but you know, I agree with Mr Torrance that perhaps a slightly different perspective, but I don't think that anything further is going to take him. I know the petitioner has been pursuing this for 2 decades now, and he must feel pretty aggrieved and disappointed. I just wanted to reflect the fact that, you know, this committee does try very hard to extract answers from the government, but very often, for whatever reason, that does not happen, and this is one of those cases.
Yes, I think that's a very fair summation of the position, and I think absolutely there is a frustration and a disappointment. Well, probably more than a disappointment now, because if anything, they probably look to the process that exists, which is the petition system that we have, and yet our system is frustrated by our not engaging directly with the issue of the petition when we don't get the responses that would allow us to do that. And if there is going to be legislation brought forward in the next Parliament, there is an opportunity, I think, to very directly address these issues in the context of the debate that takes place as that legislation progresses through Parliament. And I think that the issue is sufficiently serious that I hope that it does. But are we minded then on that basis with Mr Ewing's comments and those to close the petition? Thank you. Petition number 2006 to review and simplify the legislation in relation to the dismissal of property factors was lodged by Ewan Miller, and it calls on the Scottish Parliament to urge the Scottish Government to amend the Property Factors Scotland Act to cover dismissal of property factors or bring forward other regulations that would achieve the same aim. And this could be include giving the first-tier tribunal powers to resolve disputes relating to the dismissal of property factors. We last considered this in March, when we agreed to write to the Minister for Victims and Community Safety and the Law Society of Scotland, and in providing her response, the Minister has consulted with the Scottish Courts and Tribunals Service, and it suggests that the proposal to give small claims courts powers to dismiss property factors could add a layer of complexity that may not be suitable for simple procedure. An alternative may be to consider the summary application procedure available in the sheriff courts as a possible route to removing property factors. However, the SCTS believes that this would not be readily accessible to unrepresented parties, and it may involve awards of expenses on par with the ordinary cause procedure. The Government therefore concludes that it would not be a viable option. I think, Mr Ewing, it might have been you that floated some of these ideas. The Law Society of Scotland observes that if reforms are to be taken forward in this area, consideration would need to be given to what an excessive charge, in brackets, in inverted commas rather, means in practice. It considers that proper mediation between residents and factors is essential, and it may avoid recourse to litigation. Since we last considered the petition, the Parliament has scrutinised and passed the Housing Scotland Bill, and various colleagues lodged final stage amendments directly relevant to the ask of this petition. During the Stage 3 proceedings, the Cabinet Secretary for Housing indicated that most of the issues raised by these amendments would be addressed in an updated code of conduct for registered property factors setting out minimum standards of practice. As a result, those amendments were either withdrawn, not moved, or they were disagreed to during the Stage 3 proceedings. The Cabinet Secretary's amendment, which changed the proportion of owners required to remove a property factor from 2/3 to a simple majority, however, was agreed to. Do members have any comments or suggestions for action in relation to this? Mr Torrance.
Thank you, Convener. In light of information and the Housing Bill being voted on, I wonder if we could consider closing the petition under Rule 15.7 of Standing Orders on the basis that the changes asked for by the petition have been considered and voted on by the Scottish Parliament as part of recently passed Housing Scotland Bill.
And I think if we agree to that, we really need to point to this code of conduct that's supposedly going to address these issues that's going to be developed, because clearly at the moment expectations that the bill might have been amended to accommodate them weren't fulfilled. Do we have any option, or are we content to proceed on that basis? Again, Mr Ewing.
I agree with Mr Torrance's recommendation, and I just wanted to say that I had suggested that summary cause procedure be used, but I think that, to be fair to the Minister, she has directly responded to it. She's given reasons. I can understand that the reasons may well be valid, and my suggestion, therefore, has been answered by the Minister, and just out of interests of balance, I thought I should thank the Minister for that response. But, of course, it does mean that there is no real resolution to the petitioner's request, although I suspect that in many cases there is no real resolution ever possible where certain differences arise. That's been my experience anyway.
Okay, well, we can intend then to close petition. We are. Thank you very much. We move to petition number 2033 to introduce a pool ban on disposable vapes, introduced by Jordan Anderson, calling on the Scottish Parliament to urge the Scottish Government to legislate for a full or partial ban on disposable vapes in Scotland and recognise the dangers that these devices pose to both the environment and the health of young people. Considered again in March. And we agreed to write to the Scottish Grocers Federation asking its views on whether the ban would go far enough to address the issue. Their response suggested a number of organisations may need to be provided with significant extra resource to tackle the potential rise in illicit goods that could result from the ban. On the environmental aspect, it expresses concerns about sufficient public commitment to educate vapers about returning used vapes and about retailers potentially being expected to accept used illegal vapes for recycling in their stores as part of their provision of vape take-back. And finally, they suggest that the ban, alongside any further restrictions on affordable vaping products, could risk an increase in cigarette consumption. And it calls for a nuanced debate on the topic of vaping. Since we last considered the petition, the UK-wide ban has indeed been introduced. This means that as of the 1st of June this year, single-use vapes are no longer stocked or sold in Scotland. Do colleagues have any suggestions for action? Mr Torrance.
The committee would consider closing the petition under Rule 15.7 of Standard Orders on the basis that a ban on single-use vapes is now in force.
Thank you. Mr Golden.
I agree with Mr Torrance. I just thought it might be helpful for the petitioner, perhaps in the next session, to look at the effectiveness of this ban. I note the petition is around a full or partial ban. I would agree that in practical terms this is a partial ban, and there's numerous shops in Scotland where unfortunately you can still buy disposable vapes.
Thank you for that. Are we agreed? We are. And maybe we will get a motion, a petition in the next Parliament on a nuanced debate on the topic of voting. We'll see. Petition number 2073, to ensure accurate information is used when issuing court summons. This petition has been lodged by Robert MacDonald, and it calls on the Parliament to urge the Scottish Government to require the police and court services to check address information as up to date when issuing court summons, and allow those being summoned the chance to receive a summons if their address has changed, rather than the current system of proceeding to issue a warrant for arrest. And I think we heard, when we first heard this petition, a kind of the detailed example of how this practice had impacted. We considered it then in March, and the Lord Advocate, who has responded, echoes a previous submission from the Scottish Courts and Tribunal Service, and it highlights that if the person referred to in the background for this petition was an accused person, the responsibility to update the court on a change of address would rest with that person. The response also confirms that the processes for obtaining a warrant for both accused persons and witnesses, as set out in the past submission from the Crown Office and Procurator Fiscal Service, still stands. Additionally, the Lord Advocate points members to a statement she made before Parliament last October, in which she referenced her specific instruction that pre-conviction warrants should normally be obtained by prosecutors and executed by the police only if there is no immediate alternative securing the accused's attendance, or where the accused represents an immediate risk to others. Finally, the response highlights that HM Inspectorate of Prosecution in Scotland and HM Inspectorate of Constabulary in Scotland have initiated a joint inspection of processes for witnesses' citation and of ways in which these could be modernised. The inspection is to be undertaken over the course of this year, 2025. Do we have any suggestions as to how we might proceed? Mr Torrance.
I wonder if the committee consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government's position is that a court ask of a petition is an operational matter for the Crown Office and Prosecutor Fiscal Service and Police Scotland. Pre-conviction warrants should normally be obtained and executed in the absence of an immediate alternative, and HMS Inspectors of Prosecution in Scotland and HMS Inspectors of Constabulary in Scotland are currently conducting a joint inspection of the citation process in Scotland with a view to recommending improvements. In closing the petition, I wonder if the committee could highlight to the petitioner the option to submit a new petition in the next Parliament session should they consider that there has not been significant progress in this matter.
So, Code of Conduct will either address the issue or it will not, and the petitioner could potentially return to us. Do colleagues agree with Mr Torrance's proposal? We do. So we thank the petitioner and hope that the development of that Code of Conduct will address the matter in hand. Petition number 2084 to allow alkaline hydrolysis. This has been lodged by Randall Graham Kilgour Foggy. The petition calls on the Scottish Parliament to urge the Scottish Government to amend the Burial and Cremation Scotland Act of 2016 to allow alkaline hydrolysis, accelerated composting and other more eco-friendly methods of disposal of human cadavers. We last considered this petition on the 5th of March 2025, where I think we had all this explained to us, and we agreed to write to the Scottish Government. The response states that an alkaline hydrolysis regulations working group has now been established, and that its first meeting took place on the 3rd of March. It's currently expected that draft regulations will be laid later this year, although an exact date was still to be decided and we haven't got them yet, and the eventual timeline will be informed by the considerations of the group and the development of the regulations. Do colleagues have any suggestions as to how we might proceed? Mr Golden.
Thank you, Convener. I think that we should close the petition under Rule 15.7 of Standing Orders on the basis that expected that the draft regulations will be laid this year and that an alkaline hydrolysis regulations working group has been established and has begun exploring issues to inform the development of the draft regulations.
Which seems to be the ask of the petition. Are colleagues content that we close the petition on that basis? We are. Thank you. Petition number 2131 to grant Scottish rivers, including the River Clyde, the legal right to personhood. And this is the final of our continuing petitions this morning. It was lodged by Professor Louise Welsh and Jude Barber on behalf of the Empire Cafe, and the petition calls on the Scottish Parliament to urge the Scottish Government to grant the River Clyde and potentially other rivers in Scotland the legal right of personhood by adopting the Universal Declaration on the Rights of Rivers, to appointing a nature director to act as a guardian of the River Clyde with responsibility for upholding its river rights, and considering whether an alternative mechanism should be established to act for the rights of the river, its inhabitants, human and non-human, and society at large. And again, last considered on the 5th of March, we agreed to write to Glasgow City Region. Glasgow City Region is not able to provide a view on the action called for in the petition, as it falls outside the remit of the Glasgow and Clyde Valley Cabinet. The Cabinet is specifically responsible for the decision-making in relation to the city deal, strategic economic development priorities, as well as any other activities agreed by the authorities. We also requested more information from GCR regarding the work to deliver Clyde Mission, as well as any action that could be undertaken to formalise and improve accountability in the management of the River Clyde. The response reminds us that in August 2023, the Scottish Government transferred the lead responsibility for Clyde Mission to GCR and Argyll and Bute Council, as well as provide funding. Work on a strategic master plan was due to commence this summer, and GCR indicates that a strategic outline business case was also going to be produced alongside this in order to strengthen decision-making and underpin long-term investment. In terms of governance for Clyde Mission, the response states that for GCR, this has been incorporated into existing regional structures, and for Argyll and Bute, any reporting and approval is coordinated by council officers, with support from GCR taking place as necessary. Finally, GCR highlights that a Clyde Mission Partnership Board would also be established in due course and developed in parallel with the strategic master plan. Do colleagues have any suggestions as to how we might proceed? Mr Torrance.
In light of information before us, I would ask the committee to close the petition under Rule 15.7 of Standing Orders, on the basis that the Scottish Government does not currently support the petition's proposals. There are policy mechanisms in place to balance the interests of nature, society and the economy, and work to progress the Clyde Mission is ongoing.
Thank you, Mr Ewing. Are we content with Mr Torrance to support Mr Torrance's proposal? Yeah. We are, thank you. That brings us to agenda item 4, which is the consideration of new petitions. The first of those new petitions, and as I've kind of always said before we do consider them, that prior to the first consideration of the petition, the Parliament seeks the preliminary thoughts of the independent research body within the Parliament, SPICE, so that they can give us a proper briefing on the issues raised. And we also get an initial response from the Scottish Government. And the reason we do that, as I've explained before, is that historically they were the first two actions that we then agreed to take, and it curtails the delay in our proper consideration of the issues in hand. However, I have also said, and I know that we are now having to say to petitioners, that we're up against it with just a handful of meetings of this committee left. And even with new petitions, we're going to have to be pretty certain that there's something we can do meaningfully in the time available to us. The first of these new petitions this morning is petition number 2172, and this is to allow late proposals to alter the council tax valuation band in exceptional circumstances, and it's lodged by Sarah McFadden. I'm just wondering if that's who is with us in the gallery this morning. I'm not entirely sure. It is. A representative on her behalf. Thank you. The petition calls on the Scottish Parliament to urge the Scottish Government to amend council tax regulations to allow late banding alteration proposals in exceptional, personal or compassionate circumstances, including bereavement, illness, sudden house moves or lack of awareness of rights, particularly for tenants. Now, the SPICE briefing for this petition explains that when someone moves into a new home, they can apply to have their council tax band changed if they think their property is in the wrong band. But this application or proposal must be made to the local assessor within 6 months of the person becoming liable for council tax on that property. I suspect every MSP is aware of this because they will have had such representations to them. If the proposal is received out with the statutory time limits, the assessor must deem it invalid. So they have 6 months, and I think this isn't something that is necessarily properly understood. The Scottish Government response confirms that existing regulations do not grant discretion to extend that statutory period for proposals, even in exceptional circumstances for personal or compassionate reasons. And the Government states that because each assessor has an ongoing duty to maintain an accurate council tax valuation list, it means that anyone could request a review of the list itself and possibly a correction on the basis of a potential error and without a time limit restriction. However, as shown in the SPICE briefing, the Scottish Assessors Association suggests that the band review process is not a legislative option in Scotland, whereas the proposal process is set out in existing legislation. Additionally, evidence presented to the Local Government Housing and Planning Committee earlier this year shows that assessors are already under pressure with existing workloads. So the Scottish Government is currently conducting wider work on council tax reform, in collaboration with COSLA and based on research commissioned from the Institute for Fiscal Studies. And the Government intends for this comprehensive work to inform a debate in the Scottish Parliament in early 2026, shaping proposals for the next Parliament to consider. Members may in fact recall that we have actually recently closed a different petition on the exact basis that this is now going to be the subject of a statement, a debate and a paper ahead of dissolution and with recommendations for next year. I don't know if it's going to do all those things now I've said it, but there's certainly going to be a paper published setting out these options. Do colleagues have any suggestions as to how we might proceed? It is a new petition, but we are having to look at these things really in the light of our ability to proceed. Mr Torrance?
Thank you, Convener. And in light of your comments here, I wonder if we could close the petition under Rule 15.7 of Standard Orders on the basis that the Scottish Government is currently undertaking work with COSLA and the Institute for Fiscal Studies, which will inform potential council tax reform proposals to be brought forth in the next parliamentary session.
Now, I think it might also be worth pointing out that the future of council tax in Scotland, a Scottish Government consultation, has now just been published on Monday this week, and it closes on the 30th of January 2026. So I think it would also be sensible to suggest to the petitioner that they could contribute to that public consultation that the Government is undertaking. But in the light of those 2 points, Mr Ewing?
Yes. Again, I support Mr Torrance's recommendation for the reasons he set out, but I thought it might be useful just to reflect on the fact that the purpose of the petition is actually to allow some regard to be had to exceptional circumstances, namely personal or compassionate circumstances, including bereavement, illness, sudden house moves or lack of awareness of rights. Well, it does occur to me, Convener, that if there is to be some allowance made for these factors, particularly perhaps illness and bereavement, then perhaps the more appropriate way to give effect to that would be in the system of reliefs against council tax, rather than changing the banding. The banding relates to the category of value in which the property was deemed to fall as at the relevant date, which I think is back in 1990 or something, when the council tax was brought in to replace the poll tax. So it just seems to me this is more relief territory rather than alteration of banding territory. And I know, for example, that there is already relief against the council tax in toto for someone who is severely mentally impaired. And the process for obtaining that relief is actually not that complicated. So I just thought I'd reflect on that, because if the petitioner is to come back in the next Parliament, then the petitioner may wish to give consideration to that as an alternative route to achieving the aim that the petitioner has set out.
And I think that can be confirmed potentially also to the petitioner in the letter closing the petition, if that is what the committee is minded to do. It is. Thank you. So we thank the petitioner and hope that the consultation and the routes through which changes to council tax might be provided in the next Parliament would be a mechanism to take forward the aims of the petition. Petition number 2175 is the immediate ban on the sale and use of disposable instant barbecues in Scotland, lodged by Paul White, and it calls on the Scottish Parliament to urge the Scottish Government to table new legislation which will ban the sale of disposable barbecues by retailers and introduce on-the-spot fines for anyone using a disposable barbecue in Scotland. And we've been joined by our colleague Edward Mountain. Good morning, Mr Mountain, as we consider this petition. The petitioner believes there has been a rise in irresponsible outdoor access in recent years, which, combined with climate change, has increased wildfire risk significantly. The Scottish Government's response to the petition states that they ask if the petition is not achievable in Scotland. The submission states that product standards and safety and the regulation of the supply of goods to consumers are reserved matters. And the Scottish Government also notes that the United Kingdom Internal Market Act of 2020 generally prevents banning the sale of an item in one part of the UK which can be freely sold in the others. However, the Spice Briefing notes that Scottish ministers can introduce regulations under Section 140 of the Environmental Protection Act 1990 to prohibit or restrict the importation, use, supply or storage of injurious substances or articles for conservation purposes. The single-use plastic and single-use vape restrictions are examples of instances where the Scottish Government has sought to do this. The briefing explains that new product restrictions of this nature could require a UK-wide approach or an agreed exclusion from the UK Internal Market Act of 2020 principles. Local authorities have the power to introduce bylaws for the whole or any part of their area to put in place temporary bans on the use of barbecues, including disposable ones. And the Spice Briefing notes that the Cairngorms National Park Authority has recently submitted a fire management bylaw proposal to Scottish ministers, which, if approved, would ban the use of disposable and other non-gas barbecues in the Cairngorms National Park between the 1st of April and the 30th of September, except in certain circumstances. And before I ask my colleagues whether they have any suggestions as to how we might proceed, I'd be delighted to hear from Mr Mountain.
Thank you very much, Convener. And I understand why Paul White has put this petition in front of the committee as a matter of frustration to him and to many constituents that wildfires continue to be a problem. It was probably brought out more than anything else by the wildfire at Darver, which burnt thousands of acres. But it's on the back of other fires on the Isle of Allen and Glenfinglas where wildfires have happened because of disposable barbecues. Now, I accept the comments made by the Scottish Government regarding the Internal Market Act, and I also accept Spice's comments about the Environmental Protection Act, which may give some scope for this to happen. I think reasonably, Convener, it's not something that the petitioner would expect to be achieved in this session of the Parliament. But I think the way round it, and to allow you probably a way forward, Convener, when you come to consider closing the petition, which I'm sure you will do, and probably rightly so in the time, is to seek more clear guidance from the government of when disposable barbecues could be used. So when the fire risk goes up from moderate to high, that should be an automatic period when disposable barbecues should not be used. And I think there could also be a way of the Scottish Government making announcements when it does in relation to this, when people would be asked to abide by a voluntary ban. Now, I would just say also, Convener, if I may, the Scottish Government have slightly, by their slow action in relation to the Cairngorms bylaw, provoked this petition in itself. The Cairngorms National Park submitted a bylaw for approval to the government, and it has taken them a huge amount of time to consider it. And I'm not even sure that that bylaw has been passed by the Scottish Government as we speak today. I tried to find out, but I've been unable to do so. So my suggestion, Convener, if I might be so bold as to say, is that it might be worth writing to the Scottish Government saying that you are closing the petition and that you would hope that they would be more proactive in saying when disposable barbecues shouldn't be used, and that you would hope that there would be a speedier response to bylaws when requested by local authorities to ban the use of disposable barbecues during the course of the year. I hope that's helpful, Convener.
Thank you, Mr Mountain. Colleagues, any suggestions how we might proceed? Mr Golden?
Thank you, Convener. I agree with the comments of the member. I think we should close the petition under Rule 15.7 of the Standing Orders on the basis that, given the time constraints and likely requirement for an exemption under the UK Internal Market Act, and given the Scottish Government's track record with regards to exemptions in the UK Internal Market Act, and indeed the lack of delegation of powers and governance around the application of that Act in the UK, the timescales would mean that we as a committee cannot progress that petition within the timescales in which we have. But in closing, I agree that we should write to the Scottish Government regarding, from a circular economy point of view, how they might look to tackle disposable barbecues. And indeed, if they have or plan to engage on this specific issue with the UK Government, and indeed guidance as the member has highlighted. And finally, for the petitioner, I think it might just be worth considering, if they want to do a new petition in the next session, that were we to ban disposable barbecues, it would be relatively simple to redesign said barbecues to make them reusable. We already have examples, as a member will know, like a Hexay stove. And therefore, in terms of tackling wildfires, we're actually no further forward. We're still having a risk just with a reusable rather than a disposable product.
Thank you. Mr. Ewing?
Yes, I think for the reasons that Mr. Golden has set out, we should close the petition. However, I think having heard what Mr. Mountain has said, I agree that in closing the petition it would be helpful to write to the Scottish Government in the terms that he suggested. I would add that the fire in Dava was decimated everything, covering an area of 44 square miles, which is 1/2 of the area of the city of Edinburgh. And it is of huge concern that the next wildfire could be even worse. And an international expert in wildfires said, governments don't take this seriously until the first 100 people are dead. And I just say that not to be dramatic, but that is what gamekeepers tell me in my area, that the risk of a serious fire, which could decimate vast ways, and they can tell me exactly where it would happen and how and in what wind conditions and at what time of year. I don't think the government, although I know Mr. Fairley is taking it seriously, I do think the need for swift action is absolutely overwhelming here. So I do think that we should ask the Scottish Government whether they will work with local authorities to get a ban in place, especially in times of high risk, and especially during, I think, the months in which, the April months in which the bracken, gorse and so on in moorland is more susceptible to fire than at other times of year, although I'm no expert. So I just wanted to back up what Mr. Mountain was saying and make sure that we show the petitioner we are taking this very, very seriously indeed. Otherwise, you could see this dragging on for another 5 years whilst draft bylaws and here and there little bits of Scotland are considered instead of a national action, which I think the government should surely not abrogate to others, but take responsibility for themselves.
Thank you. Well, I think we've come to quite a hybrid position here, in that we are closing the petition, but sending the biggest letter of suggestions to the Scottish Government in so doing that we might normally have done on the basis of we're keeping the petition open. But, I mean, notwithstanding that, I think we don't expect that there'll be a lot we can do in this session, but we want to highlight these issues to the Scottish Government. I mean, I hope the clerks have been able to discern from that a course of action with which we can proceed. Is that acceptable to members of the committee?
Yes.
It is. Thank you. I would only say to Mr. Golden that the very first, he coined the phrase circular economy in the Parliament, and I do hope it's the last 2 words he says before he departs the chamber in 2026. The next of our petitions is 2176, to introduce penalties for failing to comply. And thank you, Mr. Mountain. Is to introduce penalties for failing to comply with Mental Welfare Commission recommendations related to duty of candour. The next petition is lodged by Warren Mitchell, and it does what it says in the tin: urges the Scottish Government to introduce penalties for organisations that fail to comply with recommendations made by the Mental Welfare Commission in relation to duty of candour. And the petitioner submitted this petition following the tragic loss of his wife. He believes that there were organisational failures surrounding the circumstances that should have been addressed. The petitioner believes that the Mental Welfare Commission lacks the powers necessary to take organisations to task where recommendations for improvement are not actioned. The Scottish Government's response to the petition highlights that the Scottish Mental Health Law Review recommended strengthening the Commission's powers, and suggestions included that the legislation should include a level of accountability directed to the Scottish Parliament, and this would include the power to make a report to Parliament if there is a serious failure by a public body, including the Scottish Government, to follow a recommendation. And the NWC should have the power to initiate legal proceedings to protect the human rights of any person or group covered by the Mental Health and Capacity Law. The response states the Scottish Government previously considered whether the legislation should be amended to include sanctions or penalties against organisations that fail to comply with the law. However, the Scottish Government concluded that legislation is already in place which would hold organisations to account if it was deemed necessary, and the Scottish Government is therefore not minded to amend the regulations or the overarching legislation to include sanctions or penalties. And the submission points out that health professionals will also be subject to professional standards relating to their own profession and can be subjected to an investigation and disciplinary action from their own regulatory body should they be found to be in breach of their obligations. And the Scottish Government states that it will consider strengthening the powers and responsibilities of the Mental Welfare Commission in the context of a wider long-term reform to mental health law. Well, a petition motivated by personal tragic circumstance, the position in terms of where we can go identified to us. Colleagues?
Thank you, Convener.
Mr Torrance.
Thank you. I wonder if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government considers whether the legislation should be amended to include sanctions or penalties for organisations that fail to comply with the law, and concluded that legislation is already in place to hold organisations to account. Will consider strengthening the powers and responsibilities of the Mental Welfare Commission in the context of a wider long-term reform of mental health law.
So there is a process underway, and I think it would be open to the petitioner to come back in the next session, depending on the progress in relation to the aspects of this issue that have been raised. But that is when these matters are most likely now next going to be addressed. So are colleagues minded to support Mr Torrance's proposal? Yes, we are. So we will close the petition, but as I say, write and encourage the petitioner to bear the responses that we've had in mind. The final new petition today is petition number 2177 to support and fund Motability Services, lodged by Jordan Anderson, who I think we were considering a petition of his just a little while ago. This one calls on the Scottish Parliament to urge the Scottish Government to provide sustainable funding to organisations providing mobility equipment. The petitioner has expressed that mobility services are vital for access to shops, services and community life, and his view is that without secure financial support, these services face closure, putting equality, mobility and inclusion at risk. The Spice briefing explains that funding of shop mobility varies by location, with funding coming from local authorities, health boards, charitable donations and grants. The briefing notes that there have been reports in recent years about shop mobility centres having their funding cut or reduced by local authorities or health boards, and the Scottish Government response states that local authorities are independent corporate bodies with their own powers and responsibilities and are entirely separate from the Scottish Government. The submission states that it is up to individual local authorities to manage their day-to-day decision-making and allocate the total financial resources available to them based on local needs and priorities. So, in the light of that, do members have any comments or suggestions for action? Mr Torrance.
Thank you, Convener. I wonder if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government has not indicated that it will provide specific funding for the provision of mobility equipment. It is up to individual local authorities to allocate funding to address local needs and priorities, and the committee is limited in the time remaining this session to progress the issue raised in the petition.
Mr Torrance's suggestions sensible to the committee? I mean, I do think that in this instance, again, when we write to advise the petitioner of the position that we have taken, I think there obviously is the obvious question that could be raised, with the Scottish Government about how, in the light of reduced access to mobility equipment because of inadequate funding, people with mobility issues can fully participate in their lives, communities in Scotland. But I would, I think, urge that this be something that we consider in the next Parliament. Are we agreed? So we close the petition, and I don't want to disappoint Mr Sweeney if he's here to discuss the Persons of River petition, but we've just come to the end of our proceedings having already done so. But I'm sorry to say. And that brings us to the end of our public session this morning, and we now move into private session.